Assalamu alaikum and welcome to the lecture on drug-induced hematologic disorders. The material for this chapter has been taken and adapted from Pharmacotherapy Handbook, ninth edition by Joseph T. DiPiero and internet sources. I am Shoaib Muhammad, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. In this lecture, we will be discussing about drug-induced aplastic anemia, drug-induced agranulocytosis, drug-induced hemolytic anemia, and drug-induced thrombocytopenia. Aplastic anemia is a rare disease, and in aplastic anemia there is damage to the bone marrow and the hematopoietic stem cells that are present into the bone marrow. Now, if the bone marrow and hematopoietic stem cells are affected, the different types of the blood cells, their formation will also be affected. Now, into the aplastic anemia, there may be deficiency of the all types of the blood cells, and this situation is known as the pancytopenia. If only the red blood cells are affected, we call it as the anemia. Whereas if the levels of the white blood cells are decreased, we call it leukopenia. And if the platelet count is decreased, we call it as the thrombocytopenia. Here, this table enlists the different drugs that are causing the aplastic anemia. There are two types of the evidences given here. Number one is the observational study evidence, where the this adverse effect of the drug causing the aplastic anemia has been observed into the number of the patients, while the second table shows the second column shows the case report evidences in which the adverse effects by the drugs are shown in a few patients. The observational evidences show that the carbamazepine, furosemide, gold salts, mebendazole, NSAIDs, phenobarbital, phenytoin, sulfonamides, and thiazide diuretics may cause the aplastic anemia, while the case reports indicate that the acetazolamide, aspirin, captopril, chloramphenicol, dapsone, lithium, lisinopril, nizatidine, and quinidine can cause the aplastic anemia. Now, if the patient is suffering from the drug-induced aplastic anemia, the treatment will depend upon the severity of the condition. The first step will be to stop the medication or any of the agent that is causing the aplastic anemia. If the patient is suffering from the moderate cases, we may go for the blood transfusion or the platelet transfusions, and the blood transfusions or platelet transfusions are generally necessary for the acute cases. If the bone marrow is highly affected, in these cases the bone marrow transplant is very necessary. It's very necessary into the severe cases. In this, the bone marrow of the patient is replaced from a donor, and the donor best work if he or she is a sibling, and this treatment best works in people under the age of 40 years. Next, drug-induced hematologic disorders is the agranulocytosis. That is a rare drug-induced disorder, and it is characterized by severe reduction into the number of white blood cells, the granulocytes, in the circulating blood. The granulocytes include the basophils, eosinophils, and the neutrophils. And this type of the agranulocytosis can be caused by the variety of the drugs. The common symptoms of agranulocytosis include the sudden fever, chills, sore throat, and weakness. Here are the list of the drugs that have been evidenced to cause the agranulocytosis. The observational studies shows that the beta-lactam antibiotics, carbamazepine, digoxin, gold salt, indomethacin, macrolide antibiotics, sulfonamides, valproic acid, and zidovudine cause the agranulocytosis. While the case reports evidences show that the ampicillin, cefotaxime, cefuroxime, chloramphenicol, chlorpromazine, clindamycin, grisofulvin, levodopa, and NSAIDs cause agranulocytosis. Now, if the patient is suffering from agranulocytosis, the treatment will be, in case of the no symptoms of infection are present, we will monitor the serial blood counts. We will continuously monitor the blood, that whether the white blood cells, the levels of the white blood cells are whether maintained or not. We will withdraw the causative agent which is causing the agranulocytosis, and we will advise the patient for significance of fever. We will ask the patient, if you have fever, you must report to the healthcare professional. The the transfusion of the granulocytes is the best solution to the problem, but the problem with the granulocytosis transfusion is that the life of the granulocytes is only 10 hours. So if after the continuous administration of the granulocytes, if the levels of the WBC count are not maintained, we must go for the bone transplants. There is no any other option. Next disorder is the hemolytic anemia. It is also known as the drug-induced autoimmune hemolytic anemia, and in this there is destruction of the blood cells. In this type of the hemolytic disorder, certain types of the drugs activate the immune system, and the immune system considers the red blood cells of the body as dangerous foreign substances. Now, when the immune system is considering the RBCs as dangerous foreign substances, the immune system will be producing the antibodies. And when the antibodies are attaching with the red blood cells of the body, they will cause the destruction or breakdown of the RBCs at very earlier stage. Here are the examples of the drugs that are associated with the hemolytic anemia. The observational studies have evidence that the phenobarbital and phenytoin are causing the hemolytic anemia. However, certain case reports indicate that beta-lactam antibiotics, cephalosporin, ciprofloxacin, levodopa, levofloxacin, methyldopa, NSAIDs, probenecids, and quinidine are causing hemolytic anemia. Another type of the hemolytic anemia is drug-induced non-autoimmune hemolytic anemia, also known as the drug-induced oxidative hemolytic anemia. In this type of the anemia, the drug is not activating the immune system against the RBCs, but the drugs are affecting the oxidative processes inside the RBCs, and eventually the RBCs are damaged. This is particularly likely to occur when there is an enzyme deficiency in the oxidative defense system of the red blood cells, like the glucose 6-phosphatase dehydrogenase. This enzyme is involved to overcome the oxidative stress by production of the NADPH. Now, when there is decreased level of the glucose 6-phosphatase dehydrogenase, there will be decreased levels of the NADPH. And certain drugs in these situations can affect the oxidative processes into the RBCs and damage the RBCs. The example of these drugs are the anti-malarial oxidant drug like primaquine. There are certain other drugs that can even affect the oxidative processes into the normal individuals, means those individuals who are not even deficient into the glucose 6-phosphatase phosphate dehydrogenase enzyme. These include dapsone and sulfasalazine. The non-immune drug-induced hemolysis can also arise from drug-induced damage to cell volume control mechanisms. Now, in certain situations, if the RBC is in hypotonic state, means inside of the cell the solvent is low, the RBC will take the solvent from outside the cell membrane and take up the water inside to go into the normal volume state. But certain of the drugs can affect this mechanism, and the RBC will take more and more volume, and eventually there will be swelling of the RBC and there will be lysis of the RBC. The example of the drug that may cause the destruction of the RBC through this swelling and lysis is the obane. Obane is a cardiac glycoside that was previously used as a aeropoison because it increases the cardiac activity at higher doses, and it can also be used in the treatment of the hypotension and arrhythmias. So here are the examples of the drugs that may cause the oxidative hemolytic anemia. The observational study suggests that the dapsone and guanine can cause the oxidative hemolytic anemia, while case reports suggest that ascorbic acid, metformin, methylene blue, nalidixic acid, nitrofurantoin, phenazopyridine, primaquine, sulfacetamide, and sulfasalazine can cause the oxidative hemolytic anemia. The next hematologic disorder is the thrombocytopenia. Thrombocytopenia is a condition of low blood platelet count. The thrombocytopenia can also be of two types. Number one is the drug-induced immune thrombocytopenia, in which the drugs are activating the immune system, and eventually immune system is producing the antibodies that are attaching with the platelets, and eventually the platelets are destroyed. Heparin, that is used as a blood thinner, is one of the examples that are causing the decrease count of the platelets by activating the immune system. The next type of the thrombocytopenia is drug-induced non-immune thrombocytopenia. In this, the drugs are destroying the platelets without activating the immune system. In this, the drugs are basically preventing or suppressing the bone marrow, and eventually the synthesis of the platelets from the bone marrow is decreased. This effect is mostly observed into the chemotherapeutic agents, and the valproic acid, that is basically an anti-seizure medicine, can also cause the decreased count of the platelets by decreasing or suppressing the functioning of the bone marrow. Here are the example of the certain drugs that may cause the thrombocytopenia. The observational studies evidence that the carbamazepine, phenobarbital, phenytoin, and valproic acid is causing the thrombocytopenia, while the case reports suggest that the amphotericin B, chlorothiazide, cimetidine, ciprofloxacin, clarithromycin, diclofenac sodium, gold salts, heparin, and lithium can cause thrombocytopenia. This is all for the hematologic disorder. Thank you very much for your time.